Welcome to the mandatory lecture for medication safety updates prepared by the Nursing Education Office in collaboration with the Pharmacy Department. To ensure that all healthcare providers are up to date regarding the medication management and use, as a requirement of the Joint Commission International Accreditation in CIBATI. The Medication Management and Use Standards of Joint Commission International Accreditation in CIBATI requires the organization to establish or plan suitable educational programs for the hospital's professional staff on matters related to drug use, thus making it part of the educational strategic plan and making this lecture as mandatory to all staff nurses, to acquire updates regarding safe handling of medication during preparation and administration, especially high alert medication. Participate in quality improvement activities related to distribution, administration, and use of medications. The following are the objectives to meet the accreditation requirement. Understand the standards, policy, and principles of medication administration. Define professional responsibilities related to administering medications. Assess the knowledge, skills, and attitude of the staff nurse in medication management. Know the quality improvement plan for medication management, and provide medication safety updates. Medication management and use standard encompasses the system and processes that our organization uses to ensure safe and effective use of medications to our patients. There are system and processes to safeguard the following. Organization and management complies with applicable laws and regulation. Selection, procurement, prescribing, ordering, transcribing, storage, dispensing, and distribution of medications. Preparation and administration of medications, complementary medicines, nutritional products, and contrast agents. Documentation and monitoring of medical therapies. The accreditation organization requires all staffs preparing and administering medications to be trained and competent in the principles of medication preparation, administration, and infection control techniques. Thus, the Nursing Education Office provides a medication administration and IV therapy course to certify nurses. This also requires all new staffs to complete the clinical requirements for medication administration and to annually undergo competency evaluation through the clinical resource nurse. There are also training for all equipment and machines related to medication preparation and administration, such as Omnicell dispensing cabinet, infusion pump, and system training for medication documentation. Medication hospital references are also available in the system. Patient-specific information is accessible when needed to all healthcare professionals involved in the medication management system. Thus, all healthcare provider, especially the nurses, to be aware of the following information to be included, but is not limited to. Patient information. Ensure the two identifiers are available. Age, diagnosis, vital signs, allergies, laboratory values, body weight, and height. Another JCI and CIBATI requirement is standardizing the ordering, transcribing, preparation, dispensing, administration, and monitoring of medications. Ordering. All medication orders are documented and entered in the system. To ensure safety and to avoid errors, employing independent double checks should be done. Part of the standard to meet is that the hospital develops and implements standard concentrations for all medications administered by intravenous infusion. Thus, the Pharmacy Department released to all units the age-specific dosing charts and started in the critical units the Drug Library Project.
Medication orders according to urgency. Stat orders, with a turnaround time of 30 minutes on receipt of order. Routine orders from all areas, with turnaround time of 2 hours upon receipt. The initial dose must be given upon doctor's order, and the next dose shall follow the standard timing of medication administration. All medications should follow the standard timing of administration, according to hospital policy. Time frequencies for certain medication, for example antibiotics, hypertensive drugs and cardiac drug, are always indicated in the order entry. In such case, the indicated time should be followed. Medication should be given on the hour specified as much as possible, certainly not earlier than 30 minutes, and not later than 30 minutes after the time specified. Remember that the window shadow time is different from the administration time. All medication administered is recorded for each dose. Medications are prepared in a clean, safe, and functionally separate areas with appropriate medical equipment and supplies. For the Omnicell dispensing cabinet, the nurses are responsible to clean the keyboard and touch screen only.
The nursing department complies to the accreditation requirement, for it continuously participate in quality improvement activities related to distribution, administration, and use of medications. For example, as you can see from the previous year, there is an increase of the total reported incidences such as missed and delayed administration of drug, administration to wrong patient, or with wrong dose or rate of infusion. Check closely and see if your units are in the table of the nursing department's annual reports of medication variances in different nursing units. Look at the table and check the different causes reported in the EOVR for medication variances. As you can see in the graph, the highest reported incident in the EOVR is missed in the administration. Next to the highest is the wrong dose with the changes unknown. Please check the graph and see the actual number of medication error reported by the nursing units. The following are the reasons behind the high incidence related to missed or delayed dose, late administration, medicine hanged in the bedside and not given, signed in the system before administering, and the medicine not given. Pharmacy dispensed the medicine but staff did not receive. When they request for other injection, pharmacy refused. Failed to establish the cannula, thereby missed the dose. Patient strongly refused the antibiotic. Primary nurse did not give the medicine because she was busy and gave hand over to next shift. Next shift forgot to administer. Forgot to endorse about the missed medication. For the reasons for incidents related to wrong dose with changes unknown. Miscommunication. Failed to administer the complete dose. Set the machine wrongly and wrongly set the dose. Medication reconciliation is the process of comparing the patient's most current list of medications with those ordered for the patient while under the organization. Whenever medications are used, or response to treatment or service could be affected by medications being taken. The following are the findings during the unit tracer and the most common issues and concerns related to medication reconciliation. There is a decline in compliance. Medication reconciliation was not conducted at the time of admission or discharge. In all reviewed files, there is an increased risk because of unsafe practice in the nursing units by not reviewing the patient's medication during transfer of patients. Thus, increases the risk to harm patients. Reconciled medication should be part of the handover. However, there is a poor communication practice among healthcare team, for example, improper handover, and not informing physician. The medication reconciliation should be documented upon admission, transfer of patients, or discharged. However, mostly claimed home medications are undocumented, thus putting the patient at risk. Based on the reports, there is an increased rate of medication error due to non-reconciled drugs. Always remember, nurses are responsible to obtain accurate home medication list if the medications are on hand or are brought by the patient or family. Medications that are not reconciled must be informed and addressed by the physician. Medications brought into the hospital by a patient are documented in the patient's medication reconciliation form or entered in the system as part of the medication history as appropriate, and then give to a family member to take home. If a family member is unavailable, the medications are sealed, labeled, and stored in secured place in nursing unit, and returned back once the family came to visit, or give to patient upon discharge. Remember that medication reconciliation must be done during admission, transfer of patient, after surgical procedure, and discharge. During medication preparation, observe the following: hand hygiene, cleaning of medication preparation area, checking of the 5 rights with the doctor's entry, Omnicell screen, and medication label. Practice independent double check or double check appropriately according to hospital policy. The following are the unit findings during the last Sabahi visit in our hospital. 3 out of 6 staffs were observed not applying hand washing technique. Cleaning schedule were not signed. medication prep area were not cleaned by the staffs before preparing medications. The labels did not show the expiry dates of medications. 5 out of 6 of the observed staffs did not inspect the IV products to rule out particulates or discoloration. Filter needles were not used during medication preparation. Please review the medication administration and charting policy and procedure of the hospital. In administering medications in the nursing units, make sure to always check the patient's identification using the 2 identifiers. Check the doctor's entry for the ordered or due medications. Ask patient to verbalize his name and should be confirmed with the ID band. The medication label should be checked with the ID band and doctor's order. The following are the process for medication documentation according to policy. All administered medication must be documented in the system, EMR. The home medication must be documented as part of the medication reconciliation process. The following forms are available for patient-owned meds and request for non-formulary medications. In documenting the reports for medication errors, the EOVR must be completed as soon as possible within 24 hours. For drug reactions, it has to be reported using the adverse drug reaction form. All medication-related incidences are part of the annual report of the Nursing Quality Improvement Office, and patient identification during preparation and administration are included in the key performance improvement projects as well. In the event that a patient refuses to take the medications as ordered, and as part of the patient treatment, the process for refusal of treatment according to policy must be followed. Remember that a patient has the right to refuse treatment, and it must be respected. However, as per policy, the benefits of the treatment and its consequences, if not administered, shall be explained to the patient and/or designee for 3 times. First by the primary nurse, second by the head nurse or charge nurse or social worker, and lastly by the physician to let the patient sign the refusal of treatment form. And it must be clarified that the decision of refusing the treatment is at patient's own risks. All healthcare provider must be aware of the appropriate sources of drug information that are readily available to those involved in medication use. In our hospital, check the following available drug information references in the system. Another part of the standards is that medications are properly labeled and safely stored. Medications are stored under conditions suitable for product stability. For example, products for external use is separated to internal use. The proper environment control are also monitored within acceptable temperature range. Follow the approved temperature range according to policy. Controlled substances are accurately accounted for. Any remaining narcotics will be wasted by flushing the remaining amount to the sink with running water with witness during the discarding. All medication storage are periodically inspected to ensure that medications are stored properly. Medications are protected from loss or theft throughout the hospital.
Check the following auxiliary labels or computerized alerts that is used in King Fahd Hospital according to policy. Let us discuss in details the updates in IV therapy. The report came from an external audit from BD Company, Signature Program, to check the competency of the staff nurses regarding care and management of lines and vascular access. This was done in order to develop a sustainable strategy to improve the quality of patient care at KFHU through early identification of any patient and clinician safety risks associated with vascular access. Achieve higher quality healthcare through standardization of best practice to help reduce variation and optimize product utilization. Sustain the achieved outcomes through continuous education and monitoring. As you can see from the competency rating based from the evaluation of the company representative, only 48% of the staff nurses are competent. However, in the competency evaluation of the clinical resource nurses in all the nursing units are 100%. Thus, we need to check on how we implement our nursing competency program in all the nursing units, because there is a big discrepancy within the internal and external audit. In skin prep. According to CDC, reports spanning the past 4 decades have consistently demonstrated that risk for infection declines following standardization of aseptic care. Recommendation of INS is to perform skin antisepsis using the preferred skin antiseptic agent, and allow the antiseptic agent to fully dry before insertion. Check the graph for the compliance of the nursing staff regarding skin prep. In insertion, blood exposure is a risk. Currently our facility is using IV catheters, which include blood control features, to minimize blood exposure. See the graph to check the percentage for the blood exposure of the staff nurses during IV insertion. There are still 15% who did not make use of gloves during IV insertion. For IV stabilization, INS state that stabilize and secure vascular access devices prevent complications and unintentional loss of access. The INS recommends to assess the vascular access device catheter, skin junction site, and surrounding area for redness, tenderness, swelling, and drainage by visual inspection, and palpation through the intact dressing, and through patient reports about any discomfort. However, most of the units have the practice of having non-visible insertion site, which enable them to perform site inspection and evaluation for any complication. Make sure to use transparent dressing, and to leave the area of the insertion site visible while securing the site. Always consider to use an extension set between the peripheral catheter and needleless connector to reduce catheter manipulation. Remember that access with no extension set are only for single or temporary access. Always flush the line according to policy, to avoid accumulation of blood in the extension set, and to check for patency. Vascular access devices are flushed after each infusion to clear the infused medication from the catheter lumen, thereby reducing the risk of contact between incompatible medications. The access device is locked after completion of the final flush to decrease the risk of intraluminal occlusion and catheter-related bloodstream infection, depending on the solution used. Check the graph to see the result of the survey regarding the nurse's answer to "What do you do when you observe blood in the extension set or connector?" There are still nurses who do not flush the line and just do nothing, resulting to the blockage of the IV access. Use the venous site most likely to last the full length of the prescribed therapy, using the forearm to increase dwell time, decrease pain during dwell time, promote self-care, and prevent accidental removal and occlusions. Consider veins found on the dorsal and ventral surfaces of the upper extremities, including the metacarpal, cephalic, basilic, and median veins. Do not use veins of the lower extremities unless necessary due to risk of tissue damage, thrombophlebitis, and ulceration. Opportunities to improve. There must be a standardization in nursing practice. Adherence to infection prevention protocol. Clear policy for PIVC insertion and maintenance care. Compliance on the safe sharp administration and disposal. All units should adhere to the standard practice according to the hospital policy. Part of the opportunity for improvement is to prevent the infection due to IV insertion. Make sure that the IV site is visible for inspection to check for any leakage, swelling, redness, and infection. Carrying needles and disposing in sharps collectors away from point of care lead to potential needle stick injuries. Every staff should adhere to the policy of the hospital. Line reconciliation process involve rechecking tubing connections and tracing all patient tubes and catheters to their sources upon the patient's arrival in a new setting or service and its staff shift changes. All clinical staff should include line reconciliation process as part of handover. This includes checking, rechecking, and tracing sources upon arrival in the unit, before treatment, medication administration, feeding, transfer, and change of shifts. The summary of improvement plan. Standardize policies and procedures to align with best practice guidelines. Standardize practice to align with the best practice and reduce errors by healthcare provider. Utilize the safety engineered devices available in the hospital. Continuous vascular access management, education and training program. Monitor compliance with hospital policy and procedure. Thank you for participating in our online medication safety updates lecture. Hope that this lecture will help you to ensure patient safety while rendering quality patient care in the nursing units.